One of the most famous trials in recent history was the ischemia trial coming from the United States. And my job today, in a few minutes, I know you've had a long day, so I'm going to fly through those slides, is to discuss the extension of the ischemia trial, because the ischemia trial was for about 3 years. This is the extension, which was presented by Judith Hochman on behalf of the Ischemia Extend group. So as you know, the primary goal of treatment in chronic coronary disease is either to improve survival or to improve symptoms, quality of life. So the ischemia trial, which was an NIH sponsored trial, tested an initial invasive versus an initial conservative study for chronic coronary disease patients with moderate or severe ischemia. And the primary outcome was measured MACE, 5-component MACE, and the secondary outcome was angina-related quality of life. And this, we're going to show you today the extended follow-up to compare just survival. It only looked at survival between the two strategies. It's important to remember, whenever you talk about the ischemia trial, the exclusion criteria. They're not on those slides, but they were left main disease, they were severe angina, which you can't treat medically. So all those patients had at least CT angio, and those with life-threatening anatomy were not randomized. In the original follow-up, which was 3.2 years, there was actually no real difference between the conservative arm and the invasive arm. But there was a durable improvement in angina control and quality of life with the invasive arm if the patients originally had angina. This was the original study. There was no difference in death, no difference in cardiovascular death, and no difference in non-cardiovascular death. So the extension was looking at the mortality. We just looked at the mortality. Will patients who have been treated conservatively die more because their arteries were not treated with stenting or with bypass, or will they live well? And this was the ischemia extend, and it was for the follow-up survivors of the ischemia trial, and this was the extra follow-up of median of 5.7 years. So this looked at the deaths, and the additional deaths that happened during the extended period of follow-up was 268 deaths, making the total death at 5.7, 557 deaths. And guess what? There was no difference in death and mortality in the extended period between the conservative arm and the invasive arm. But very interestingly, cardiovascular deaths were less with the invasive arms. And the interventional cardiologist said, yeah, good. So patients are dying less from cardiovascular causes if they have an invasion. But the non-cardiac deaths, non-cardiovascular deaths were actually better with a conservative approach. And this nullified the benefit of the less cardiovascular deaths with the invasive approach. So in the end, there was no subgroup, no interaction that you could pick and say this group from chronic coronary syndromes or very stable patients do better with invasive or than conservative. It just did not happen. The probability that one strategy is better than the other for the all 7-year cause death could not be achieved. There was no probability which was better than the other. So the ischemia extend was designed as a pragmatic long-term follow-up study of mortality. We're just looking at mortality with limited data collection. There was no data collected on non-fatal events, on use of medications, on revascularization, or quality of life beyond the original follow-up period of 3.2 years. The cause of death, cardiovascular versus non-cardiovascular, was adjudicated during the original trial phase, but not during the extended phase. So no adjudication. The strategy did not test routine revascularization for those with angiographic findings suitable for revascularization. And routine cardiac catheter revascularization was compared with selective catheter revascularization only based on clinical need, acute coronary syndrome or refractory angina. So what was the conclusion? The conclusion was that the extended follow-up of the ischemia randomized trial over a median 7-year period demonstrated that the initial invasive strategy compared with the initial conservative strategy resulted in no difference in all-cause mortality. More patients died during the follow-up. There was a lower risk of cardiovascular mortality with the invasive strategy and a higher risk of non-cardiovascular mortality with the invasive strategy. And the implications actually provide evidence for patients with chronic coronary syndrome and their physician to decide if they want to add invasive management to guideline-directed medical therapy. So patients should not be scared into choosing that. And then there was the interesting arm of the ischemia CKD, which was again presented by Sripal Bangalore on comparing the survival at 5 years of follow-up. This is the ischemia CKD, and this was the original ischemia CKD at 2.2 years. There was no difference between the conservative strategy and the invasive strategy. And the cardiovascular death and the death were the same in CKD patients. However, very interestingly, procedural MI, which is basically a troponin rise, which does not normally kill you, was higher with the invasive strategy, while spontaneous MI was actually lower with the invasive strategy. So there was some benefit in this group. However, at 5 years of randomization, the ischemia CKD, there was a much higher rate of death than patients without CKD, but the initial invasive strategy and the initial conservative strategy again resulted in a similar survival at 5 years. So the conclusion, I'm finishing 5 minutes earlier in case somebody wants to discuss, was that the ischemia extend and the CKD and the ischemia CKD extend confirmed the results of the original ischemia trial. This is further proof of the robustness and the durability of the original trial, because followed up for 7 years, there was no change. PCI does not improve survival in patients who are clinically stable, who are sometimes very ischemic and sometimes have severe coronary artery disease. Those patients can be treated medically if that is their preference. If the patient, you must remember that those results are not extendable to patients who are not studied in the trial population. So patients, for example, with left main or severe proximal LAD disease were excluded. So these data are not extendable to them. Patients with severe angina were excluded. You cannot treat patients with severe angina medically and say this is based on the ischemia trial because they were not studied. So please, whenever you talk about the ischemia trial, just go to your AI or Google and just read the exclusion criteria and in your mind, remove those patients. But for the majority of our stable patients without left main disease who are doing well on medical treatment, the data we have now is that you can still keep them on medical treatment. Thank you very much, and I'm happy to take any questions.